Mike, thank you very much, and thanks for the opportunity to be with you. And I'm very pleased to be able to come. I do hope you've all had a very interesting and productive conference. I was fascinated myself to see one of the hazards of being Secretary of State is that you get to come and talk, but you don't get the opportunity to come to the conference and listen as much as you would like. And I think in the past I was able to do that a bit more, but I could see that this conference has clearly been one that anybody who came to it would have had more than a sufficient to keep them interested and to give them thought and provoking thoughts for the future. And Mike, thank you for those kind words. Indeed, over the last 12 years, I think I'm not alone in regarding NICE as becoming increasingly respected, literally not just this country, but perhaps even more so around the world for its professionalism and objectivity in making crucial decisions about the merit and value of interventions to treat or to prevent illness. And during that time, of course, NICE has been no stranger to controversy. It's made difficult and sometimes unpopular decisions. You will forgive me if I say that doing what is right, making decisions that one feels genuinely are in the best interests of the NHS and of its patients and of the public we serve, that is far more important than being popular, although being popular would occasionally be nice. Now, throughout all of that, you've shown the mettle, the professionalism, the determination to make difficult decisions, and I think at NICE you can be very proud of the job that you do. Of course, in the future, things aren't going to get any easier or any less controversial, but neither will the role of NICE be any less vital in the ongoing life of the NHS. In fact, your role will, if anything, be more important. Now, it clearly hasn't escaped Mike's notice, or yours, that we have a new Health and Social Care Act. It's an act that has a significant impact upon NICE itself. NICE is currently established in secondary legislation as a special health authority. Technically, as I've been fond of telling people across the service is, in many respects, whatever the Secretary of State wishes it to be at any given moment. So, for example, the Secretary of State could, at the stroke of a pen, abolish NICE. I felt strongly NICE deserves more than that. As an organisation as important as NICE should be established in primary legislation, it should have its independence guaranteed. Indeed, the Health and Social Care Act, a large part of it is about giving that sense of permanence and stability. Tough as it's been for people to go through the changes that we are going through, the objective is not to have changes year by year, not to have arbitrary, politically inspired changes on an annual basis. So in that sense, NICE, established in statute as in primary legislation, should have not only independence guaranteed, but that level of stability for the future. And as the National Institute for Health and Care Excellence, NICE will have the legislative footing such that the extent and limitations of ministers' influence over it will be explicitly set out. The Act does other things too, from the way we commission services to structures to organisations that will lead and shape the new NHS. Now, throughout the reforms, there are a number of important themes that will have a significant impact on NICE itself and the way it operates in coming years. Three of them, the importance of evidence, the need to maximise value, and the need to improve services through integration, I want to talk about today. The first is the importance of evidence. I want to see an NHS that is clinically led, not micromanaged by politicians, an NHS where people can be confident that the decisions being made about their care are based on the best evidence of what works. It has to be asked, if there is no evidence, if a treatment is not the most appropriate one available, if it represents very poor value for the taxpayer, why then is the NHS doing it? Evidence is central to everything we want the NHS to do. One of the most exciting changes that is happening is the availability of huge amounts of clinical outcomes-based information for clinicians and for patients alike. Just pick up a copy of the Atlas of Variation, now in its second annual edition, and you can see at a glance sometimes the huge variation in clinical outcomes across the country. For too long, the focus, including in the public debate, was just on the average. That hid a multitude of sins. For while some in the NHS provided their patients with world-class care and the taxpayer with value for money, other parts of the NHS failed to do so and were let off the hook, hidden within aggregate statistics. No more. Evidence and transparency must be written through the heart of every decision the NHS makes, in every GP practice, every hospital, every clinical commissioning group across England. This must be the case throughout the health and care system. Evidence will underpin the future also of public health. With the new Public Health England drawing together data from strengthened surveillance and practical experience from frontline delivery, its partnership with NICE, drawing together evidence from the research community, will be vital to producing timely, reliable and comprehensive evidence. Evidence supports excellence and accountability. It makes people accountable for the decisions they take and the outcomes they achieve. And NICE will be central to that. The Health Act makes NICE stronger than before. For the first time, your remit will stretch beyond the NHS to cover social care, both for adults and for children. The new quality standards will bring common ambition to all parts of the NHS, not setting out the minimum that we should expect, but the excellence we should strive for. Aradazi started the ball rolling back in 2008 with his report, High Quality Care for All, and we've picked up that pace and that ambition. One of the first things I was able to do as Secretary of State was to publish the first quality standards nearly 2 years ago. There are now 17 quality standards. In coming years, there will be as many as 170. Quality standards should be a backbone for the commissioning system. I know that the NHS Commissioning Board shares that view. Information, of course, is a lifeblood to patient and professional empowerment, as well as a means of focusing on quality and outcomes. Already, we publish more information on more clinical areas than ever before. Increased numbers of clinical audits. The NHS, for example, more effective at preventing infections, less bogged down, more effective at generating information, less bogged down in pointless data collection. People now can see at a glance how good the quality of care for a range of conditions is in their local area through the atlases of variation, including, of course, the new Children's Atlas of Variation as well. People can log on to NHS Choices, and members of the public can find out a large and growing amount about GP practices, hospitals and community services. Through NICE Evidence, NICE provides a world-leading online service that gives people working across health and social care access to a comprehensive range of quality-assured evidence. And through NICE Pathways, to see how they can relate to that information and NICE guidance to their own treatment and pathway of care. So rather than taking potluck on the quality of what they find on the internet, users can be guaranteed that the resources on NICE Evidence and NICE Pathways are available to help them make informed decisions about treatments and resources. We will shortly publish our information strategy, a strategy that will see a revolution in the use of data within health and social care, making evidence and data central to every decision taken by clinicians and patients alike. Now, closely intertwined with evidence of the most clinically effective treatments is the evidence on the best value for money treatments. A lot of the time, that is where the decisions get really difficult. But if the NHS is to continue as a provider of high-quality universal care, free at the point of need, then it is imperative that while we seek to improve outcomes for patients consistently, we also constantly look to secure the most value out of every penny the NHS has. I profoundly disagree that the job of clinical professionals is solely to treat the patient in front of them without regard to anyone else. As the GMC's guidance for doctors states, doctors have a duty to the health of the wider community. So I think the ethical responsibility of all NHS staff is not only to provide the best care and the most appropriate care for the patient they are caring for, but also to understand and act on information about the implications for other patients, or all their patients, of the use of resources. That is fundamentally, of course, one of the essential purposes of clinical leadership coming together in clinical commissioning groups, so that we align together the use of resources with the clinical decisions for which clinicians are responsible. Now, central to this is making sure that we use the most effective and the most innovative medicines. Currently, we use the Pharmaceutical Price Regulation Scheme, PPRS, which is effectively a negotiated rate of return scheme for pharmaceutical companies. Of course, for a time, that has worked well and provided stability to the pharma industry, but that stability was progressively undermined, not least as governments prior to our own interfered mid-term with the working of the scheme. And of course, it failed effectively to promote the use of new innovative treatments or increased access to those new treatments to the extent we wished. Now, I am determined we should secure not only value for taxpayers, but also a reward for innovation and a clear focus on realizing the benefits to patients of that innovation. Now, from January 2014, there will be a successor to the PPRS for existing medicines, and for new branded medicines, there will be a new system, value-based pricing. NICE will be vital to this too. If we are to get a much closer link between the price the NHS pays for treatments and the value that patients and society derive from them, then we will need evidence and professional opinion on which to base these decisions. Now, as enshrined within the NHS Constitution, the NHS in England will continue to fund existing drugs that have been recommended by NICE. That right will continue and will also apply to new medicines to which value-based pricing applies. The NHS Chief Executive's report, Innovation, Health and Wealth, set out an explicit commitment to ensuring NHS compliance with NICE appraisal guidance. It was clear that local NHS formulary processes should support implementation of NICE guidance, not act as a barrier. And it set out plans for a new NICE implementation collaborative to support NHS bodies in putting NICE guidance into practice. NICE will examine the evidence on the potential clinical and cost effectiveness of new drugs as they become available, drawing on its world-leading expertise in this field. Importantly, under the new system of value-based pricing, NICE will no longer be obliged to make yes-no decisions on access based on its own cost per quality thresholds. Instead, you'll be free to focus on the rigorous appraisal of evidence to show the relative benefits of a new medicine. There will be price ranges under value-based pricing, reflecting the aspects of value, including not only additional therapeutic benefits, but also the quality of innovation, the response to unmet need, and societal benefits. The resulting pricing thresholds will be set as part of the value-based pricing mechanism by government rather than by NICE. Of course, for NICE, no longer constrained in that way, your appraisals will therefore be even more applicable across the world, strengthening not only your international reputation, but the applicability of NICE appraisals in other health systems. Because your appraisal methodology and assessment of incremental benefits are transferable results. Cost per quality thresholds are not often transferable in the same way, since they inevitably reflect differing price comparisons and price elasticities in other health systems. Clinicians will always need advice they can trust and depend upon to make the best decisions for their patients. Through the new system of value-based pricing, I hope those options available to clinicians will include more new and innovative treatments that may not have been available so readily under PPRS. By carrying out a broader assessment of a medicine's value, taking account of unmet need, value-based pricing will mean we will be able fully to reflect the added value to patients and society in what we pay. For example, we might pay more for a medicine that helps people with greater needs or where there is no alternative treatment, thus encouraging innovation and meeting more of those unmet needs. But conversely, there will be some medicines which do not bring this kind of value and for which we could in future pay less. As has been the case with PPRS, I hope the new arrangements can be agreed through a process of negotiation. Those negotiations will start in the latter half of this year. Third theme, where NICE will play a significant new role, is through integration. It's hard to think of an area of medicine that can stand entirely on its own. All modern healthcare is a team effort. But if we are serious about improving outcomes, we can't remain confined within a worldview that stops at the door of the hospital or even the GP surgery. Back when the NHS was new, a typical patient would have been a lot younger and fitter, with just generally one discrete condition. Today, they may be very different. Go into a hospital ward or a GP waiting room, many of the people you will see will be older, and they may well be suffering with several long-term conditions, each of which may have an impact on their lives. It's not enough just to look at improving clinical outcomes. We need to improve the whole experience of care for patients, and we need to do far more to keep people healthy and out of hospitals. Again here, NICE will be central. We see time and again for too many people how care is fragmented. People move from one part of the health and social care system to another. Each time, to them, too often, it feels like they're starting from scratch. Sometimes when people are at their most vulnerable, they can be subject to experience that they find the most disorientating. Too many hoops for patients to jump through, too many administrative obstacles, all getting in the way of what they see as the proper integration of services built around them as a patient. The new Health Act integrates NHS social care and public health like never before, mainly because we need them to be unified like never before. Just as patients can't afford the clinical consequences of disjointed or fragmented care and the poor outcomes it would lead to, nor can the taxpayer afford the additional expense that fragmented care inevitably leads to. Unnecessary emergency medicine, unnecessary long stays in hospital, unnecessary delays in discharge, all waste millions of pounds and have a negative impact on the lives of patients. That is another reason why NICE's role is being expanded. From April 2013, NICE will not only be responsible for producing guidance on healthcare and public health, but also on adult and children's social care. So NICE's reputation for excellence, for experience in engaging with and listening to the people who will benefit from that guidance, means NICE is well equipped to carry out this new and essential role. I want the new health and social care system to deliver better quality care, more personalised care, to deliver for people longer and healthier lives, and to reduce inequalities between the richest and poorest in society. In short, I want better outcomes. Time and again, NICE has proved that it has people, the skills, the sensitivity, the objectivity to lead the way within the NHS and in public health. Decisions that you, NICE, have taken have helped ensure that millions of people get the benefit of the best drugs and technologies, and that their clinicians know exactly what the best and latest treatments are. Evidence, value, and integration. Three themes that will reach to every part of the NHS, three areas that NICE will drive forward. I'm very glad to be here this year at this year's annual conference, the last before NICE takes up its further and extended role, to encourage NICE in giving that impetus and that leadership across the health and social care systems. Thank you very much.